increase cardiac activity, sodium and water retention, and promotes aldosterone secretion, which again causes sodium and water retention, and vasoconstriction, and overall elevated blood pressure. And this sympathetic nervous system and system trigger cardiomyocyte hypertrophy and myocardial fibrosis. Initially, this leads to an increased left ventricular mass, which enhances heart's pumping against excessive afterload. However, when progressive, net result is left ventricular stiffening and impaired diastolic function. Initially, there will only diastolic dysfunction. Then, as the disease progresses, the subacute rise in LV and diastolic pressure may cause increased wall tension, compression of subendocardial microvasculature, and myocardial ischemia. Over time, this contributes to LV wall thinning, dilation, and eventually systolic dysfunction. Then there are two types of hypertension: primary or essential hypertension. Its cause remains unknown. 90% of patients with hypertension, it will be a primary hypertension. Then there is a second category called secondary hypertension. There is definite cause which we identified. The causes of secondary hypertension include the endocrine causes like Cushing syndrome, hyperaldosteronism, oral contraceptive use, pheochromocytoma, and in case of thyroid diseases such as hyperthyroidism. Then pulmonary diseases, obstructive sleep apnea, then renal conditions such as chronic pyelonephritis, diabetic nephropathy, nephritic and nephrotic syndrome, polycystic kidney disease, and renal artery stenosis. Then toxic or metabolic causes of secondary hypertension include chronic alcohol abuse and sympathomimetic drug abuse and thiramine containing foods. Then vascular causes of secondary hypertension include atherosclerosis and about hypertensive emergencies. So a true hypertensive emergency is defined by presence of acute target organ damage and is distinct from other clinical presentations, such as patient may usually present a headache, dizziness, but with elevated BP, but that may not be account for hypertensive emergency. So true hypertensive emergency, there will be signs and symptoms of end organ damage, such as chest pain in case of acute coronary syndrome, and in case of is weakness of limbs in case of acute ischemic stroke, and breathing difficulty in case of acute pulmonary edema. There will be definite the definite signs and symptoms of end organ damage. Then incidence of these hypertensive emergencies by organ. Heart has the highest cardiovascular diseases are the highest incidence. 27 to 49% of hypertensive emergencies may be related to cardiovascular system, and acute heart failure alone contribute to 40 to 37%. Next come the acute ischemic stroke, hemorrhage, and hypertensive encephalopathy. Then hypertensive emergencies to kidney involves only 50%, and other causes such aortic dissection, eclampsia, acute hypertensive retinopathy, which all has small incidence. Then hypertensive, next about hypertensive emergencies. Then diagnostic category include acute aortic dissection, hypertensive emergency which may cause end organ damage. And first about acute aortic dissection, signs and symptoms include chest pain and back pain, unequal blood pressure in the upper extremities. Acute, it can be diagnosed by CT angiogram of chest or transesophageal echocardiogram. If hypertensive emergency causing acute pulmonary edema, there will be a patient have dyspnea, we can clinically will get basal curbs on auscultation, and there will be B lines on focus and interstitial edema on chest radiographs. Then acute myocardial infarction. Signs and symptoms include chest pain and autonomic symptoms. We can detect by changes in the ECG and related cardiac biomarkers. Then acute coronary syndrome, like chest pain and autonomic symptoms, and we can diagnose by ECG and biomarkers. uh, Acute renal failure, which may have systolic and diastolic serum creatinine, elevated serum creatinine level may be associated with acute renal failure. Then, in case of pregnancy, there can be severe preeclampsia. And eclampsia symptoms include seizures, shortness of breath, headache, and blurred vision. And we usually diagnosed by proteinuria, and blood tests include low platelet count, renal insufficiency, and elevated liver enzymes. Then hypertensive retinopathy, there will be a blurred vision. We can detect it by fundoscopy. Then next category include hypertensive encephalopathy. There will be altered mental status associated with nausea, vomiting, and headache. Then on fundoscopy, there can be papilledema, and MRI, there can be uh, cerebral, only cerebral edema. There in CT we not find anything. On MRI we can find cerebral edema. Then hypertensive emergency can also cause subarachnoid hemorrhage, intracranial hemorrhage, which present as the focal neurological deficits, and acute ischemic stroke present as neurological deficits, which can be found in CT or MRI. Then acute perioperative hypertension, there will be a bleeding, unresponsiveness to direct pressure. Clinical diagnosis, it's made by the manifestation of the hypertensive emergencies. There also can be a sympathetic crisis, so it may be caused by the usage of sympathomimetic drugs, and it clinical features will include anxiety, palpitation, and tachycardia. Then diagnosis of this hypertensive emergencies according to the signs and symptoms, and we send appropriate lab tests, and like CBC, to look for the hemoglobin count in case of any microangiopathic hemolytic anemia. Then serum creatinine and serum electrolyte to look for the kidney injury, and ECG and cardiac biomarkers can be helpful in diagnosing end organ damage to heart caused by this hypertension. Then focus also helpful in diagnosing the acute pulmonary edema and chest X-ray. And brain imaging like CT head or MRI useful in like acute ischemic stroke or hemorrhagic stroke. Then in case of aortic dissection, CT, transesophageal echo, or MRI can be used. Case of hypertensive retinopathy, fundoscopy or digital fundus photography can be used. Then treatment of hypertensive emergencies. Then patient present with hypertensive emergency should be admitted to a critical care setting for continuous monitoring of BP and target organ function. Use IV antihypertensive to reduce systolic blood pressure no more than 25% in the first hour. If stable, then reduce to 160 to 100 millimeters of mercury to next 2 to 6 hours, then to normal over the following 24 to 48 hours. It is to avoid hypoperfusion to the vital organs. So in the first hour, BP should not be decreased by more than 25%, then decrease to 160-100 over the next 2 to 6 hours, then to normalize over 24 to 48 hour period. More aggressive blood pressure control is needed for acute aortic dissection, where the target BP is less than 110 Target systolic BP is less than 110 in acute aortic dissection and pheocytoma crisis and severe preeclampsia or eclampsia and acute intracerebral hemorrhage. Then pharmacological agents. Commonly used pharmacological agents include first alpha blockers, phentolamine, and beta blockers include esmolol, metoprolol, and mixed alpha and beta blocker include labetalol. Then angiotensin converting enzyme inhibitors, AC inhibitor, enalapril, and calcium channel blockers, which are dihydropyridine calcium channel blocker include cleptipine, nicardipine, and nohydropyridine calcium channel blocker include diltiazem and verapamil, and direct acting vasodilators include hydralazine. Then dopamine receptor and agonist like phenoldiazepam also used. Then loop diuretics such as furosemide, bumetanide, and torsemide used. And natriuretic peptide receptor agonists like nesritate used. And nitric oxide donors for vasodilation, which include sodium nitroprusside, nitroglycerin, and isosorbate dinitrate. Then goals of the treatment of hypertensive emergency. In case of acute coronary syndrome, we have to diminish cardiac workload and improve coronary artery perfusion. So primary nitroglycerin, you use nitroglycerin, which dilate peripheral vessels and decrease systemic vascular resistance, so thereby decreasing cardiac workload. It also decreases preload, which helpfully decreasing cardiac output. So overall, BP will be decreasing. In acute heart failure syndrome, goal of treatment is to reduce impedance to forward flow and diminish cardiac workload. So primarily NTG, nitroglycerin, and furosemide are used. In case of aortic dissection, we have to reduce the shear force. LV ejection should be decreased. So rapid acting beta blockers which reduce heart rate and cardiac output, such as esmolol used, and associated with it sodium nitroprusside also used. In acute ischemic stroke, we have to reduce the hemorrhage conversion and edema of nearby area while avoiding regional hypoperfusion. So only primary we use nicardipine. Then in case of intracerebral hemorrhage, reduce hematoma expansion and perihematomal edema. Primarily nicardipine is used. In case of intracerebral hemorrhage, aggressive management is required, but in case of ischemic stroke, aggressive management is not required. To reduce perfusion should be maintained in case of acute ischemic stroke. So aggressive management of BP should be avoided. In case of hypertensive encephalopathy, goal of treatment to reduce brain edema, to reduce intracranial pressure. So primarily nicardipine is used. Then in case of acute kidney injury, goal of the treatment to decrease pressure in the renal parenchyma and glomerular apparatus. In case of acute kidney injury, clevidipine and nicardipine will be used. In case of preeclampsia and eclampsia, we have to decrease intracranial pressure while maintaining placental perfusion. So primarily hydralazine used and secondarily labetalol is used. Then we have to treatment of hypertensive emergencies elaborate by. In case of once more aortic dissection, we have to reduce shear force. So lower SBP to 100 to 120 and pulse rate below 60. So we have to use rapid acting IV beta blockers like esmolol. In case of acute hypertensive pulmonary edema, BP should be reduced by 20 to 30%. Associated with it, diuresis should be achieved to decrease preload, and we use nitroglycerin IV and associated with furosemide also used. In case of acute MI, to reduce, goal of the treatment is to reduce ischemia. So we have to avoid 25% reduction of mean arterial pressure. So nitroglycerin or esmolol used. Then acute sympathetic crisis, we have to reduce the excessive sympathetic drive and to aim for BP less than 140. So benzodiazepines or nitroglycerin can be used. And as we said, an acute renal failure to be reduce BP by no more than 20% acutely. So nicardipine, phenoldiazepine, clevidipine use. In eclampsia and preeclampsia, BP should be less than 140. So hydralazine or labetalol can be used. In case of hypertension and encephalopathy, to decrease intracranial pressure, decrease MAP in 20 MAP by 20 to 25%. So labetalol or nicardipine. In case of subarachnoid hemorrhage, systolic blood pressure should be less than 160 to prevent nicardipine IV or labetalol IV bolus with continuous infusion can be given. She said, next about intracerebral hemorrhage. If systolic blood pressure is more than 220 millimeters of mercury, consider the aggressive management with IV infusion. If systolic blood pressure is between 150 to 120, IV boluses of antihypertensive should be used acutely lower SPP to 140 millimeters of mercury. So we use labetalol IV bolus on or continuous infusion. So BP should be reduced in case of intracerebral hemorrhage. In case of acute ischemic stroke with RTP candidate, if fibrinolytic therapy is planned, if treat if BP remains more than 185/110 only. So we have to use cautiously in case of acute ischemic stroke. In acute ischemic stroke, if BP is more than 220/120 millimeters of mercury, BP should be reduced only 50% in the first 24 hours. And same agents like labetalol, nicardipine can be used. Then dosage of the IV agent for hypertension emergency. Labetalol we given us bolus doses 10 to 20 milligrams of over 2 minutes. Then continuous infusion 2 milligram per minute and titrate up to 300 milligram of total dose if needed. It is safe in pregnancy. Esmolol used in the aortic dissection. It's ultra short acting cardioselective beta blocker. Loading dose is 250 to 500 microgram per kilogram infused over 1 to 3 minute IV, and maintenance dose is 550 microgram per kilogram per minute IV or 4 minutes. Then calcium channel blocker like nicardipine. Then continuous infusion start at the rate of 5 milligram per hour. If target BP is not achieved within 5 to 15 minutes, increase by 2.5 milligram per hour. And every 15 per hour, every 15 to 5 to 15 minutes until target pressure is reached. Hydralazine we have given 10 milligram slow IV infusion. Maximum initial dose is 20 milligram and repeat every 4 to 6 hours as needed. Then nitroglycerin, if given a sublingual, give 0.4 milligram. If in case of continuous infusion, start in dose of 5 microgram per minute. Increase by 5 microgram per minute every 3 to 5 minutes to 20 microgram per minute. If no response at this dose, and increase by 10 microgram per minute every 3 to 5 minutes. And nitroprusside, continuous infusion 0.3 to 0.5 microgram per kilogram per minute IV initial infusion, and increase increment as 0.5 microgram per kilogram per minute. titrate to desired effect. Then elevated in patients with no endocrine damage but with elevated BP, what to follow. For patient who lack acute endocrine damage, immediate antihypertensive therapy is needed. However, emergency clinician can play an important role in the care of this group, providing screening and ongoing surveillance to prevent secondary complications of the disease. If the patient's BP is between less than 140 bar 90, we have to advise lifestyle modification and OPD follow-up. Uh, if the patient's SBP with between the less than 140 bar 90 with risk factors involved, we can initiate antihypertensive with follow-up in less than 1 month. The BP is more than 140 and less than 180, and diastolic BP is between 90 to 110, we have to initiate antihypertensive therapy, ideally with 2 agents. Follow up within 1 month. If the BP is more than 180 by 110, we have to evaluate for the endocrine damage and initiate lifestyle modification along with 2 agent antihypertensive therapy and follow up in OPD within a week. Thank you.
Shaheem, that's it. Go back to your slides. First one. Okay, the second one. Okay, what is BP?
Blood pressure.
Yeah, I know. Definitely.
Instead of BP, it is the
question is open to all.
exerted,
Anybody can answer. Yeah.
pressure exerted by blood flow of blood to the wall of the artery.
Okay. Okay, this is your understanding. May I get the definition as a definition, please? Yeah, you're right. Okay, anybody else can try? Avantika?
Force of circulating blood.
What?
Force of circulating blood effect of the arteries.
No, Shaheem gave the answer, but the specific word I'm looking for. Okay, and Shaheem, can you tell me about the Poislow's law? Poislow's law. Poislow's law. It's a French name. Sorry, I can't pronounce it any better.
Oh, which law, ma'am?
Poislow's law. Don't.
Poislow's.
Yeah. Okay, Deepak, can you try? What is Poislow's law and what is the relationship with the hypertension? Deepak? Oh, my class. Okay, Avantika?
Flow is blood flow is related to the volume resistance.
Any other tries? Any other better answer?
Inversely proportional to the fourth power of radius.
Sorry. Come again?
Directly proportional to the fourth power.
Okay. Anybody in this group giving part A? Nobody?
Trying this time next time.
Trying. Okay, fine. Okay, refer. I'm not going to tell the answer. Okay, the blood pressure is the latent pressure exerted by the moving column of blood against the wall of a blood vessel. Okay, so provided the relationship between the Poiseuille's law is and the Laplace law, you should refer these two laws. Okay, I'm not going to brief you people. So these two laws have like very significant role in hypertension and we managing the fluid resuscitation in the ED and also the cardiac failure. So what the Poiseuille's law say is like the pressure difference in a vessel, in a given vessel, the diameter of the vessel, the tension in the vessel, and the thickness of the vessel plays a major role. So what does it mean?
The flow rate is
Yeah.
the
So when
flow
the hypertension strikes in, what happens to the flow?
flow
What happens to
flow
the flow?
decreases. Flow decreases.
Decreases.
It decreases. So what is the pathophysiology of systemic hypertension and the chronic hypertension? Okay, whatever happens in the hypertensive crisis. Elaborate.
In systemic vascular resistance increases in
Okay.
case of hypertension.
Sorry, I can't get you. Come again.
Vascular resistance is increases in hypertension.
Okay.
So that thickening of the vessels will be there and radius will be reduced.
Okay. So that's all.
No, also affecting the cardiac output. In case of increased sympathetic activity, cardiac output will also be increased. To cope with the systemic vascular resistance, LV, left ventricular hypertrophy will occur,
Mm.
which
Only heart is
initially,
being targeted in this. Edwin? Any better pathophysiology?
Same. Shaheem said.
See, we have regulatory things in a system. So we have vascular regulatory things also. Like how come if we bleed, the vascular regulatory things happen? So the vascular regulatory things will shift to the right. You know the curve. We have this vascular regulatory curve for every other target organ. Like brain is separate, the cardiac is separate, and everything. This regulatory curve shifts to the right. It means it is like we need a perfusion pressure should be more for perfusing this organ when the patient is already hypertensive. The regulatory mechanism will wean off in particular time. At that time, what will happen?
at
So there
that
will
time,
be a mechanical change happens in the arterioles. So the artery will go for like mechanical wall stress and endothelial injury happens. What if the endothelial injury happens?
it's a thickening of the
The coagulation pathway will start off. What will happen if the coagulation things start off?
thrombosis and
There will be coagulation, platelet aggregation, fibrin, and there will be fibrinoid necrosis of the arterioles. Okay, that causes then what? Just see, fibrinoid necrosis is happening, coagulation is happening. So the patient is hypertensive, all these changes are happening. So target organs, look into the target organs. What is the target organ? Kidney. Okay, what will happen in the kidney? When the patient bleed, don't we see hematuria, microscopic and macroscopic?
yes.
The patient is symptomatic or asymptomatic? Don't we see like fundoscopy examination, all those hypertensive changes in the eye? Don't we
Yes.
see the LVH? So this is not the end organ damage. This is the ongoing organ damage. Okay, after this, what happens? And further kick in the prostaglandins, free radicals, cytokines, mitogenic, and chemotactic agents, and all the others. All others kick in, and what happened? Furthermore, endothelial damage. And for this, the muscle, the muscle in the blood vessel have to regrow. It have to proliferate. And here comes the Poiseuille's law again. The muscle of the arteriole is getting thickened and the flow, how come the blood will be? It is viscous, it is not watery. And here comes the Laplace law. So what happens? There will be hypoperfusion. And here comes in your RAS from the kidney. What will the angiotensin do? What is the RAS first of all? Somebody
First.
explain the RAS.
Renin release,
What?
angiotensin
Angiotensin?
converted into angiotensin 1, then 2.
And 2 by what? From where?
Then
Angiotensinogen is secreted from what?
From liver.
Okay, it is converted into angiotensin 1 from by what?
By renin released from kidney.
Okay, then angiotensin 1 to 2 by
And
what?
2 by angiotensin converting enzyme.
angiotensin converting
released
Okay,
enzyme.
what is
from lung.
angiotensin 2? Then
Angiotensin 2 will be doing this increase sodium and water
vasoconstriction.
retention.
And
Sodium water retention
what
occurs.
happened to the
Aldosterone.
aldosterone?
So again, the blood pressure increase.
What happens to the aldosterone? It's renal.
Aldosterone increases secretion from adrenal. Angiotensinogen promote the aldosterone.
Yes.
It,
What does it do?
it also act on receptors in DCT to sodium to increase sodium and water retention.
Yes. So the volume depletes.
Volume.
So already we are having hyperperfusion because the vessels are not good and the RAS is also setting in. What happens now? There will be hyperperfusion further and ischemic changes in the end organ. So that is what the patient presents with. So the end organ damage is not something presenting ongoing process. So if there is end organ damage, what is insist? See, all the mechanisms, all the regulatory mechanisms are done. So we are going to intervene. So this is the pathophysiology of hypertensive crisis. Got the point?
Yes.
So all the people will refer the Laplace and the Poiseuille's law.
Okay.
Again, go back to the next slide, please.
Classification.
Shaheem, I don't know from, I think most of your pictures are cut copy paste from Cincinnati. Please don't do that because everybody can't put up an attention. There are very important points to be noted. So only that you have to mention. We can't run through this. This is really a bad thing I want to tell. See, the presentation is all good. The topics has been given to you a month back, if I'm not wrong. Please put some effort, type in and put only the points needed to be seen or taken home. Okay, like running through the pages, I can do it at home. Everybody can do it at home. Okay, all those things you studied, you read in the slides, it's not useful. Okay, Edwin, can you just name the hypertensive emergencies in the ED? Just fast. I have so many things to say, but I can't.
Hypertensive ischemic stroke,
Okay.
renal acute kidney injury,
Okay.
Acute pulmonary edema,
Okay.
myocardial infarction,
Okay.
aortic dissection,
Okay.
intracranial hemorrhage,
Okay. Any other things?
eclampsia.
Yes. Okay. So I just want the things he ran through in the pages. I just want to mention one thing. Jack of all trades, master of none. So anybody knows what is the specified drug for each of this condition? Okay, I'll ask one by one. What is the drug of choice for eclampsia?
labetalol,
How? Okay, how will you give? What is the thing you have to notice in giving labetalol? What is the cautious being about? Okay, I will also give labetalol. What I has to be conscious about? What?
Bradycardia should be.
Bradycardia in who?
In fetus.
Okay, then only bradycardia in fetus. Hypertension also in fetus. Then I'm giving a beta blocker in a pregnant female. Won't you be worried about the respiratory system in that female? who's already had the compromised respiratory.
COPD or asthma should be avoided.
Yeah. See, this is how your class should be. Okay. If you're mentioning something, the important thing about that drug or administration should be talked more, not like running through all the things which has been put upon the books. Okay. Okay. You're treating an acute coronary syndrome. What is the drug of choice?
Nitroglycerin.
What?
Nitroglycerin.
NTG.
NTG. Fine. Okay. Nitrates. Then I don't have a nitrate. Okay, you will give nitrates to everybody. You will give nitrates to all the ACS.
No, it's elevated blood pressure. See,
Elevated blood pressure you won't give. Okay, for that only you will give. Okay. Okay. You are giving for every other elevated blood pressure you will give what?
Inferior wall.
Is there any okay inferior wall? Okay, you won't give. Any other contraindication for giving nitrates in ACS?
if there
Any history?
Oh,
Cardiac history?
phosphodiesterase.
Yeah. What is that?
sildenafil and
Why? Why? Why is it so specific? What is the interaction?
Also,
It will cause severe hypertension in the patient. Even patient can die. Okay. What is the drug of choice for press? Did you discuss about encephalopathy, hypertensive encephalopathy?
just I mentioned about encephalopathy.
You mentioned because it's there in your Cincinnati page. That's it. You didn't talk about it. Okay, fine. This is I can't grade this class because I can't talk so much because you didn't talk much. So let next class be better. Please don't put cut copy paste. I don't know whether your seniors also like did all these same things and you people are following your footprints of your seniors. Please don't do it. Please type your slides and highlight what the things should be taken home. And about the drugs, mechanism, and everything, type in your own words. It will be helpful for you and also the other people. And that's all. Nothing more. Anybody have any other question? See, disposition of the patient is one important thing from ED. Nobody is, touching about disposition. Any given topic, the patient comes in, you investigate, you examine, you treat, and what? You will have the patient in the ED. Proper disposition has to be discussed in every other topic. Disposition in the sense where the patient will end up, the home, the hospital, the critical care, or whatever it is. And the definitive treatment should also be discussed. Okay?
Okay.
So that's it, guys. Yeah, we'll leave the class.